All right, good morning, everyone. Thank you. Glad to be here. I want to thank the organizers for inviting me. I think you guys put together a fantastic meeting. Really a chance to renew, recharge. I reconnected with a lot of old friends, which I haven't seen in many years in person. And I met some new friends, so I feel like I know many of you in the audience already from the hikes and the yoga sessions and whatnot. So really glad to be here, and let's get started. So I know you guys are relaxed because of Diego, so thank you for that. But I need you to wake up, okay? We're gonna talk about leukemia, the best of ASCO in terms of what leukemia abstracts are out there. Now I'm gonna try to cover all the leukemia. So I have 20 minutes. We have 4 or 5 leukemias. What I tried to do is pick at least one abstract from each of the major subtypes, AML, CLL, CML, and ALL, and MDS. And instead of sort of going through the entire abstract and the study and what it pertains to, what I'm going to try to do is distill really the key points of these abstracts and how it can be potentially practice changing. And the abstracts that I've chosen are things that I think that are going to be practice changing. So unlike breast, unlike GI, we don't have phase 3 clinical trials which are massively changing the standard of care in leukemia, just because there's smaller studies. Some of the randomized studies were presented at meetings at EHA and ASH. But the ones I'm going to present, I think, will give you a taste of what is to come and how we're going to use some of these new therapies going forward. So we'll start with CML, chronic myeloid leukemia. Many of you treat this in the clinic. And the study I'm going to talk about is the phase 3 study called ASSEMBLE, which is a study of asciminib versus bosutinib in patients with CML chronic phase who have failed 2 or more prior tyrosine kinase inhibitors. So if you remember in CML, it was sort of the poster child for targeted therapy in cancer. We have the BCR-ABL translocation, which leads to CML, and we've developed many different tyrosine kinases that inhibit the ABL kinase, starting with imatinib, dasatinib, nilotinib, bosutinib, ponatinib, 5 different TKIs. They all target the same kinase domain ABL. The problem with that, as you know, is you treat these patients for a long period of time, they start getting resistance mutations. And as they become resistant, one TKI stops working, you switch to a different one, that one may stop working, and so on and so forth. The one T315I mutation is actually resistant to all of the TKIs except for ponatinib, and that remains one of the few options for that particular disease subset. And so this is actually a different tyrosine kinase inhibitor called asciminib. It does not bind in the same pocket as the ABL kinase as the other IBs that we usually use, as imatinib and Gleevec, and ponatinib and the others. And so it actually binds to a separate pocket, so-called allosterically separate area in the enzyme. So it's not affected by the same kinase domain mutations that we typically see that actually render resistance to the other TKIs. And so asciminib is an interesting study. And so what they did, so as you know, asciminib is currently approved by the FDA for patients who have failed 2 or more tyrosine kinase inhibitors. That failure could be failure of activity, so not achieving major molecular response, or if they were intolerant to that therapy and they can move on to a different one. As you know, each of the TKIs has its own sort of side effect profile, and so this helps asciminib fit in this groove of adding activity in places where patients need treatment. So this was a randomized study, and this is actually a late follow-up, a 2-year follow-up, so-called 96-week follow-up, which is the secondary endpoint. The primary endpoint was achieved at 6 months, which is major molecular response. And so patients with CML in chronic phase who had received 2 prior tyrosine kinase inhibitors were randomized either to bosutinib at the standard dose 500 or asciminib at 40 milligrams twice daily. Now you've had to either fail or be intolerant to the prior TKI. So intolerance doesn't just mean, hey, I'm responding great, but I'm having a little rash, I'm going to slip over. It's people who are intolerant but also have not achieved a major molecular response. So it was rigorous criteria for enrollment, and they were randomized between these 2. I'll point your attention to the bottom where in people who are on bosutinib, who could not tolerate for whatever reason or could not get a sufficient response, they were allowed to come off and cross over to asciminib, but that population was analyzed separately. It's not included in this presentation. So as I go through the data, and I'm going to go through it quickly because it's just highlight points, the thing I want you to recognize here is the duration of treatment for each of the 2 drugs. So on the left is asciminib, on the right bosutinib. You can see that a large proportion of patients discontinued treatment who were on bosutinib. Okay, so the patients, 50% of patients on the asciminib arm had continued ongoing treatment with asciminib, whereas only 20% on the bosutinib arm. So as you look at the data in terms of the major molecular response, the duration of response, keep in mind that those patients on the bosutinib arm actually had less treatment because of the intolerance, because of the toxicities, because of coming off treatment and therefore that could have contributed to the lack of efficacy, not necessarily to the TKI alone. Now, what the trial doesn't tell us is what attempts were made to keep people on bosutinib. So you start at 500 milligrams, and if anyone who treats CML with bosutinib at 500 milligrams, you know that you quickly come down to 400, 300 milligrams based on response and tolerability. Was that done? It's not clear. Nonetheless, as you can see, the primary endpoint, which is on the left, to 24 weeks, significant improvement in major molecular response at week 24, at week 48, at week 96. In the back of the room, you can see asciminib clearly met the primary and secondary endpoints of higher rates of major molecular response, thus suggesting it's an important drug in that setting of failure of 2 TKIs. Similarly, if you look at the duration of cumulative incidence of MMR over time, you can see that at every time point, the curves are separating. Asciminib seems to have higher and higher rates of major molecular response compared to the bosutinib, thereby suggesting this is a very important drug for this patient population. What about side effects? And so when you're treating people with chronic agents like TKIs, I think side effects and maintaining compliance is so important. And you can see here that there's a sort of a big divide, right? So bosutinib, as you all know, causes a ton of diarrhea. So GI toxicity is a major side effect of bosutinib. But what you also know is after 3-4 months of therapy, potentially reducing the dose slightly, the diarrhea goes away and people tend to tolerate it well. But you can see there's a high rate of GI toxicity with bosutinib, almost none with asciminib, whereas with asciminib, there's a slight increased risk of myelosuppression, slightly higher incidence of cytopenias than you saw with the bosutinib. So there's a trade-off there, but again, even the myelosuppression is not as severe with the asciminib, and so I think that's the trade-off that you see. And the GI toxicity is likely the reason why many people came off and therefore did not have efficacy. So as a key point, bottom line, it's an important option for patients with CML. So if you have patients who have failed 2 or more TKIs, you have issues with GI toxicity, asciminib is an excellent and important option. Higher rates of MMR at those 3 time points, better tolerated with lower rates of GI toxicity and a slight increase in heme toxicity. And again, keep in mind with the caveat that more patients did come off to bosutinib due to intolerance and therefore less exposure compared to the asciminib. So that was our CML abstract. Going to AML, acute myeloid leukemia, we've had sort of a dramatic revolution in that disease, as you know, with the introduction of things like venetoclax, IDH1 and 2 inhibitors. We've realized with the use of next-generation sequencing that we're really able to individualize therapy, that AML is not one disease, but probably 60 diseases defined by their cytogenetics and their molecular characteristics. And so one of the ways people are using this is that the advent or the availability of next-generation sequencing. And I know many of you in the audience and the speakers yesterday have spoke about next-generation sequencing and how they're being used in liquid tumor biopsies and circulating free tumor DNA for solid tumors. Well, we've been doing this in AML and leukemia for many years, and this is sort of a culmination of that and potentially a view of things to come. So one of the major areas of research in acute myeloid leukemia after achieving remission is that almost everyone relapses, right? 60-70% rate of relapse over the long term. So how do you prevent those relapses? Well, those relapses come from somewhere. They come from minimal residual disease, which we can detect. For years, we have been using flow cytometry methods, which is surface markers, to detect minimal residual disease. Now, people are starting to use next-generation sequencing because of the depth at which you can get reads, 1 in 100,000 reads, so you can really detect at a very sensitive level residual leukemia based on now their mutation. So if a patient has a FLT3 ITD, a FLT3 D835, or NPM1 mutation at diagnosis, you treat them, they're in complete remission. And it's funny, one of the comments that the speaker made when they presented is, there's no such thing as a complete remission. He's right? Less than 5% blast, their counts recover, everyone's happy, they get a few cycles of consolidation, and then a year later, everyone relapses, right? So are you really in complete remission? And so these studies allow us to see that there are still probably tens if not hundreds of millions of cells, leukemia still present at a very low level, which then give rise to the relapse. And so with next-generation sequencing, we're now able to detect these things. And so the CIBMTR, which is a large organization for stem cell transplant, was able to get a hold of samples on 1,075 patients who had blood work done 100 days prior to their transplant. And the question they asked is that if they had mutations in FLT3, NPM1, IDH1 or 2, or KIT, and if they were mutated, can we detect those mutations pre-transplant? And does that detection predict for overall survival and predict for relapse-free survival? And the short answer is yes, it does. But there are caveats, so let's get into that. So first, they took the overall group and they found that indeed, it does. So people who had negative or undetectable mutations prior to transplant had improved relapse-free survival, which are the yellow curves on top, improved overall survival, reduced relapse-free survival, but it did not affect non-relapse mortality. So the detection, as you would expect, of the disease predicted for relapse and predicted for death from relapse, not for non-relapse mortality. And so that was the thing. Then they looked at the individual mutations. So which mutations are prognostic? You heard yesterday from Mark Lewis that there are so many mutations you can detect, and there's a lot of noise, so to speak, so-called CHIP or clonal hematopoiesis. And so I'll get into that in just a minute here. But they looked at individual mutations. Are all the mutations prognostic, or are certain ones? Indeed, they looked at FLT3-ITD, which is present in about a third of patients with newly diagnosed AML. If that was detectable, higher rate of relapse and reduced overall survival in that subset. Patients who had NPM1 mutation, this has already been shown in a New England Journal of Medicine. Patients who had detectable NPM1 prior to transplant had higher rates of relapse, poor overall survival, and poor relapse-free survival. FLT3-TKD, this has never been shown. FLT3 tyrosine kinase domain mutation, which is a different one. If that's detectable prior to transplant, same thing. It predicts for worse overall survival, worse relapse-free survival, and higher rates of relapse. What about IDH? Turns out IDH is not prognostic, right? So the presence of an IDH1 or IDH2 mutation prior to transplant did not predict for worse outcomes, did not predict for worse relapse-free survival, worse overall survival, or increased relapse risk. So it tells you that not every mutation is important. And this is a lesson that's sort of extended from a previous study. So the so-called DAT mutations, which are DNMT3A, ASXL1, TET2. And if these mutations are present at the time of remission, they actually don't mean anything. They don't predict for overall survival. They don't predict for relapse-free survival. And similarly, the presence of the IDH1 mutation does not predict for this. What we think, why is that? We think that the reason for this is that this is maybe part of their clonal hematopoiesis. As you age, you develop mutations. Some of those mutations are clonal, and they develop a clonal hematopoiesis, sort of the soil from which the AML develops. And if you can get back to that soil, as long as you don't have another secondary hit or a secondary mutation, you may actually not have a relapse, but may have sort of a low-level MDS-type disease for a period of time. And so it's very interesting. The other thing they found is that if they used melphalan-based conditioning, and this is for sort of highly specialized transplanters in the audience, but if you use melphalan conditioning, you could actually blunt the effect of that. So if you had positive mutations and used melphalan as part of your low-intensity conditioning regimen, you could actually blunt some of the relapse-free survival detriment and overall survival detriment that you get with persistent mutations. And so you can almost eradicate some of those mutations potentially with melphalan-based conditioning. And so this is just some of the things I told you. NPM1, FLT3, and FLT3 D835 are predictive of relapse-free survival, overall survival. IDH1 and 2 are not, and potentially melphalan-based regimens may improve outcome in those patients who do have positive MRD. And so in practice-wise, this is good for the transplanters. If someone does have detectable disease, can we intervene? Can we give them a melphalan-based regimen to get them to better outcomes? Acute lymphoblastic leukemia. So for years, we've been using, if you guys treat ALL, a multi-agent chemotherapy regimen in acute lymphoblastic leukemia. This was derived from pediatrics. We now cure about 80 to 90% of pediatric acute lymphoblastic leukemia. That same approach was used in adults. As you can imagine, adults may not be able to tolerate as intensive chemotherapy, so there are certainly more side effects, and also the disease is a little bit more ominous in adults. And so we have tried to push towards a non-chemotherapy or a reduced chemotherapy-based regimen in acute lymphoblastic leukemia. The place that we're able to do it really well is in Philadelphia positive disease because we have a potent tyrosine kinase inhibitor. And so this is one of the first trials. This is in combination, the other one is blinatumomab plus dasatinib, one of the first trials using no chemoctherapy, just monoclonal antibody blinatumomab, which is a bispecific antibody which targets CD19 and CD3 and allows the immune system to sort of clean up the leukemia, and ponatinib, a highly potent BCR-ABL antagonist for this disease. And this is some of the background that I mentioned here. Blinatumomab is used in relapsed and refractory disease with a remission rate of 36%, and the current standard of care in the front line of newly diagnosed Philadelphia positive AML is chemotherapy, hyper-CVAD usually, with ponatinib. And what they did in this therapy is just gave blinatumomab monoclonal antibody with a pill, no chemotherapy. Some of the patients that I treated with this, and this was done at MD Anderson, were surprised that they weren't getting chemotherapy. They didn't lose their hair. They felt great the whole time. One lady said she'd rather go to hospice than to get chemotherapy. We said, great, I'm not giving you chemotherapy. So she is currently doing extremely well, working full-time, and very happy. So you can see in the front line, relapse rates, remission rates, 96% CR/CRi rate with a complete remission rate of 91% and complete molecular remission of 85%. Again, no chemotherapy, folks. just blinatumomab and ponatinib. Even in the relapse and refractory setting, you can see there in Philadelphia positive, high response rates. The one place that's funny that we did not see the high response rates is in so-called CML lymphoid blast crisis. So for those people who know about CML and blast phase, you can have a CML myeloid blast phase and a lymphoid blast phase. And the lymphoid blast phase essentially looks like Philadelphia positive ALL. But if you do fish on the neutrophils in the peripheral blood, you see the BCR-ABL in the myeloid cells as well as the lymphoid cells, hence telling you that this is actually not ALL. And what they found is in CML lymphoid blast phase, indeed, the responses weren't as good, and they actually do need chemotherapy. And so with the two places you can see, just at the end of cycle 1, 64% had a complete molecular remission. That means you could not detect BCR-ABL after one cycle of blinatumomab monoclonal antibody with ponatinib. Very, very high rate of complete molecular remission, and overall is 85%, but also pretty active in the relapsed refractory setting. These are the outcomes so far with a median follow-up around just a year, under a year, 11 months. Event-free survival, overall survival, straight line in people with newly diagnosed Philadelphia positive ALL. And you can see in the relapsed refractory setting, not bad median survival, 15 months in relapsed refractory Philadelphia positive ALL. So very encouraging data, and certainly longer follow-up is needed and broader applicability. We only use this in our older and unfit patients because we still use chemotherapy in the young people who can tolerate chemotherapy. What about CLL, chronic lymphocytic leukemia? Probably much more common in your practices just because it's a more common disease. One of the things in CLL, again, a huge revolution, right, in chronic lymphocytic leukemia, we move away from chemoimmunotherapy, where we used to give things like FCR or bendamustine rituximab for patients with CLL. Now we have targeted agents, right? It's completely revolutionized the thing. So we use things like ibrutinib, which is a BTK inhibitor, acalabrutinib, venetoclax, just oral medications, pills that actually lead to complete remissions and extended patients' quality of life, overall survival, and relapse-free survival. One of the downsides that people often talk about with these drugs is that, gee, I have to keep taking this drug forever. Whereas FCR, I give you 6 cycles, you're done. Potentially, your disease won't come back for years. But with these other drugs, I have to keep taking them like a hypertensive medication. Not that that's a bad thing sometimes with cancer, but certainly people wanted to look at fixed duration. Can we get to a point where we combine these drugs, get to such a low level of minimal residual disease that we stop the drug and just wait? And that's what fixed duration therapy is. And so this is the long-term follow-up of the Captivate study, where they combined ibrutinib, which is a BTK inhibitor, with venetoclax, a BCL2 inhibitor, in patients with CLL. So patients with newly diagnosed CLL will initially treat with ibrutinib for 3 months, 3 cycles at the standard dose, 420 milligrams. And at month 3, they started, month 4, they started venetoclax. And the venetoclax was ramped up as you would normally do, 20, 50, 100, 200, 400. And then they were continued up to 12 cycles of the combination. And after that, you stopped. 1 year of therapy and stop. No therapy. And so many people were nervous. Hey, what are we going to do? What they relapse? Well, you just treat them again. It turns out that these patients had an amazing response. High rates of undetectable minimal residual disease, okay? Improved overall survival compared to what you would expect from traditional chemotherapy-based methods. And these were not just favorable risk, easy patients. If you look, many of them had high risk features, including over half the patients had unmutated IGHV, P53 mutations, 17p deletions. These were, fairly good smattering of high-risk patients. And what they found is the complete remission rate at the long-term follow-up improved to 57%. 79% of those patients had undetectable MRD in the peripheral blood and in the bone marrow. And when they stopped at 12 months and they continued to check for minimal residual disease after that, 3 months, 78% of them remained undetectable MRD, suggesting that this stop approach may actually be something that may be beneficial. Again, more follow-up is needed. This is about a 3-year follow-up, and people are still doing fairly well. As you can see from these curves on the right side, that's overall survival. These are people who received 12 months of therapy with these 2 drugs, oral medications, stopped, and are being observed. Okay? There is a bit of progression-free survival, meaning some people are relapsing, and you can see the types of patients who are relapsing are those who have adverse karyotype, P53 mutations, unmutated. But it turns out if you retreat those patients with ibrutinib, they go right back into remission. Okay, so 11 of 12 patients who did have some progression, the high-risk patients, they were given ibrutinib and they went back into remission, usually a partial remission. It was well tolerated, most of the toxicities being some arthralgia, as well as diarrhea, nausea, and neutropenia. So fixed duration therapy in CLL, it's coming, folks. We're testing it. Hopefully we can make this a reality and monitor these people very carefully going forward. And finally, the last I'll leave to the last is the MDS. So myelodysplastic syndrome, again, very common in our patient population that we see in the clinic. Most MDS is treated with HMAs. There is a subgroup of MDS, which of course is very difficult, and of course its cousin AML are the P53 mutated AMLs. And so P53 mutations, again, present in many of the cancers that you all treat, predict for resistance to chemotherapy, poor outcomes, and reduced overall survival, same in MDS and acute myeloid leukemia. It's inherently resistant to chemotherapy because presumably it does not stop the cell cycle when it experiences DNA damage or cell stress, allows the cells to continue. So what if we were able to use an immune-based approach where the immune system was activated and was able to control the disease? So Magrolomab is a CD47 monoclonal antibody, a so-called "don't eat me" signal that's present on the tumor cells or the cells in question. If you cover up the "don't eat me" signal, that actually allows the macrophages and the microenvironment to actually exert their immune effect on the cells. It's sort of an immune checkpoint for macrophages, if you want to think of it that way. And so they looked at Magrolomab in MDS, high-risk MDS, but mainly I want you to focus on the the last column, which is those patients who have P53 mutated AML, where the response rate is usually around 20%, with the survival in the range of 4 to 6 months in AML, and maybe about 6 to 10 months in MDS. And you can see here that the response rates are actually fairly good. Overall response rate, 68%, but 40% real true complete remission rate, which is fairly high for this patient population. And you can see that their median overall survival was not reached. And if you could divide it by the P53 mutated versus wild type, those who had P53 mutated had a median survival of 16 months, which is significantly better than what you would expect historical controls, like I said, in the range of 10 months for myelodysplastic syndrome. And as a last bonus, I threw this in there, a similar abstract at the same meeting presented in acute myeloid leukemia with an overall response rate of 49% and a complete remission rate of around 50%, which is what you would expect typically with single-agent hypomethylating agents. But you can see with the waterfall plot there, significant improvement in blast count. And so these are drugs that are now being studied in randomized phase 3 trials to see if this does actually improve outcomes in this very difficult subtype. So this is the median survival, and I'll stop there. Thank you for your attention, and I'm happy to take questions.
One is, we heard individual residual molecular changes prior to BMT and pre-measure trial. What about residual complex molecular changes? And what about combined cytogenic changes and new molecular changes?
Yeah, it's a great question. So clearly, molecular testing allows a really deep analysis of and so it's very sensitive to even the smallest. Cytogenetic changes are present at a frequency of 1 in 20 or 1 in 100. And so clearly, complex cytogenetic changes or any changes prior to transplant is equivalent to residual disease or minimal residual disease. And so those also predict for poor outcome, and that's been studied as well. The second question was combined cytogenetic and new molecular changes. Certainly, if you have any cytogenetic changes present prior to transplant, that's going to predict for poor RFS. For new molecular changes, that's an interesting question because what you see is that these things evolve. And so patients actually, they may clear their original mutations, but pick up new mutations, most often P53, which is a resistance mutation. That does often predict for relapse-free survival.
Okay, second question. Is it outdated to start newly diagnosed chronic phase CML on imatinib? Do we have cost effectiveness comparison?
That's an amazing question. So, you know, it's an important question in this day and age with sort of the economic or financial toxicity that we see with many of these drugs. I don't necessarily think that it is outdated. I think if you're in a situation, and we do this frequently even at MD Anderson, in patients who don't have insurance or who cannot afford the co-pays even when they do have insurance, to get continued drug for forever. So imatinib is still an excellent drug. I think if you continue to follow them and monitor according to ELN guidelines and hit the milestones, and you're hitting them well, you can continue imatinib. There are all kinds of pharmacies out there. I think Mark Cuban has an online pharmacy that gives it to you for $40 a month or something. So I think it's certainly not outdated in the patient population if they cannot have access to the TKI. Many of my colleagues abroad in other countries use imatinib very, very effectively, and certainly if you don't have access, it's an important option.
Okay, I'm going to give you one last question. What's the highest age of patients included in the ponatinib and blinatumomab trial? In community practice, how do you handle blina toxicity?
So I'm going to look up the highest age. I don't remember offhand, but it probably should be here. So, oh, it's not here. I think it was in the late 70s, maybe early 80s. So blinatumomab toxicity, we hospitalize our patients for the first week during the dose step up when you go from 9 to 27. And as soon as they are able to tolerate that, they go outpatient. They get the weekly bag, so they come back once a week to get recharged. If they do get blina toxicity, you educate the patients and their family members. It's going to be terrifying because it looks like they have tremors, which is the low grade, but sometimes they look like they have a stroke, where they become aphasic, they have heavy paresis, they have facial asymmetry. So in those patients, we say, bring them to the emergency room. Don't freak out. This is maybe expected. You bring them to the emergency room. We educate our ER doctors to stop the infusion, to give them Decadron, and to get them admitted to the hospital for further workup before we try the re-escalation. So we're able to do it effectively, and they just educate the patients and their families.
Sorry. One audience question. Let me just grab it.
With the Blincyto, have you seen research or anything regarding extramedullary disease?
Yeah, it's a good question. We actually have debates about this all the time. So, it's not, there are some studies that suggest it may not be as effective in certain extramedullary disease. And so patients who have lymph nodes or skin disease or other things, we tend to give them a dose of chemotherapy or steroids or something to get that under control and then proceed with blinatumomab. There's no rigorous data testing that, but if you look at some of the trials, particularly relapsed refractory trials in patients who had extramedullary disease, the response has not been as robust. And so in those cases, I would potentially use chemotherapy, low dose, or maybe some steroids or something to debulk that. And CNS disease, also, sorry, but one last point, all of these patients had CNS prophylaxis with intrathecal therapy. So that's important, 12 intrathecal therapies, because CNS, the incidence of CNS disease in Philadelphia positive is so high that it's important to keep those going. All right, thank you.